This segment of Delmarva Life is brought to you by Peninsula Regional Medical Center.
As we get ready to close out National Stroke Awareness Month, we would like to take a little time to help you better understand stroke. After all, studies show it is the leading cause of serious long-term disability in the United States.
Yeah, after someone suffers a stroke, conditions such as slurred speech or paralysis might come to mind. But of the nearly 800,000 people who have a stroke every year, many of them will also have problems with swallowing. That's why teams that address that issue are so vital. Kaylin Asbury is a speech-language pathologist at Peninsula Regional Medical Center and joins us this afternoon. Thank you for being here this afternoon.
Thank you.
So we're talking about dysphagia. Can you help us understand it?
Yeah, so dysphagia is just a fancy word for swallowing impairment. So when people have a stroke, we're looking at different areas of the brain that are impaired, and there are several areas of the brain that do control swallowing. So it's a common issue after one occurs. So it's something that we assess for all of our stroke patients in the hospital.
So can you figure out how severe the stroke is by how well they swallow?
So in some cases, yes. It depends on the area of the brain that the stroke occurs, because in certain areas when there is damage, there is a more severe swallowing impairment than others, and it depends on how large the stroke is as well.
Wow.
And then any other pre-existing conditions that the patient has too.
Now these assessments that you do, they're pretty important, aren't they?
They are. So we start in the hospital, we start by visiting the patient right at the bedside. We're looking for a few different things. We want to assess their muscle function in the mouth and the throat. We give them different consistencies of foods and liquids to see how they tolerate it at the bedside. And we're listening for any wet gurgly sounds in their voice, any coughing, any throat clearing, because that does indicate that something is happening that shouldn't be. And for us to know for sure, we turn to instrumental assessment. My job would be much easier if I had x-ray vision, but I don't.
It just doesn't work that way.
No, it doesn't work that way. So we do mainly two types of assessments. So the first is called a modified barium swallow study, where we get a nice profile view of the patient, and it's kind of like a video x-ray. So we mix different food consistencies and liquid consistencies with barium, and then we can follow that liquid and that food from the mouth all the way down the throat to the esophagus and make sure that it's not entering the airway.
Right.
And then another assessment that we do is called FEES, or fiber optic endoscopic evaluation of swallowing. I'd stick to FEES, it's easier to say. So it just gives us a different view. It actually involves a scope going through the nose and looking down at the vocal cords and the airway to make sure that food is not entering when people swallow.
So the silver lining of all this is you can offer treatments.
Yes.
How do you help patients with this?
So I kind of put treatment into two camps. There's the compensatory strategies that we use, which is essentially exactly as it sounds. We're compensating for the problem, so we might offer different swallowing and feeding strategies while someone's eating. We may have them turn their heads, maybe even change the consistency of what they're eating and drinking, like thickening a liquid or making something softer. And then we also have the rehabilitative approach, which conquers the strengthening of the muscles that are causing the impairment in the first place. So compensatory strategies are like the Band-Aid approach, but then you essentially have to fix what's causing the real problem too.
And oral hygiene is also important.
Yeah, so for a lot of our patients, keeping the mouth clean is incredibly important, because we have a lot of bacteria in our mouths, and when someone aspirates food or it goes below the level of the vocal cords towards the lungs, it can carry that bacteria with it, and it makes people more susceptible to getting aspiration pneumonia, which can cause even more complications throughout their progress after
We're out of
stroke.
time, but I want to ask you real quick. You've seen this with patients. Have you seen some outstanding results?
Yeah, in fact, I can't put my finger on one specific thing, but my favorite part of my job is when I see a patient, I do their assessment, and they've had a feeding tube from such a severe swallowing impairment, and then I get to tell them, yes, you can eat again because you've made so much progress. That's my favorite thing about my job.
That's a good day.
I bet, I bet.
Yep.
PRMC speech language
so much.
pathologist
Thank you so much.
Kaylin Asbury, thank you.
Thank you.